All right. Well, hello and welcome everyone to Diaceutics' latest event. We're glad you joined us for this talk. Today, our speaker is Professor Giancarlo Pruneri from Milan University and the National Cancer Institute of Milan, who will be discussing biomarker testing for ADC in cancer patients. Here's a look at today's agenda. My name is Ian Moore, and I am a Network Development Manager with Diaceutics. I'll provide a short background about Diaceutics as a whole, as well as DXRX, our precision medicine platform for labs. I'll then turn it over to Professor Pruneri for his presentation. At the end of the presentation, we'll dedicate some time for Q&A where we'll answer your questions. Please note you can ask questions at any time during the talk by typing them in the box below this presentation. Diaceutics is an end-to-end services provider and data analytics company specializing in precision medicine. Our mission is better testing, better treatment, and we are building towards a future where the testing ecosystem allows all patients to receive the right treatments at the right time. We believe that labs need to be involved earlier in the precision medicine decision-making process. We have experience in 96 disease pathways and have worked on every precision medicine brought to market with 36 of the top 40 pharma clients. And we have a global presence across 53 countries, which enables knowledge sharing across a vast range of topics. All diagnostic labs can find a benefit from a DXRX registration, regardless of shape or size, and we see this collaboration having a positive patient impact all over the globe. Our goal is to break down global barriers between labs, and we see DXRX as the way to accomplish this. With a free DXRX membership, you receive free access to our data dashboards, visibility to Diaceutics and pharma-sponsored collaborations for both labs and pathologists, a curated feed of CDX and precision medicine news and resources, as well as additional lab-focused webinars like the one you are watching now. As we work towards our goal of better testing, better treatment, Diaceutics wants to highlight an organization that shares many of our same values. PathologyOutlines.com was established in 2001 with the mission to provide useful, professional information to practicing pathologists and lab personnel in 15 seconds or less via a free and continuously updated textbook. This online textbook is comprehensive and peer-reviewed, written by pathologists for pathologists, and touches on over 4,600 topics. They offer all pathologists a free, editable webpage for life through filling out a survey, and they are currently looking for authors. For those interested, you can send your CV in areas of interest to nat@pathologyoutlines.com. We encourage everyone to visit their website and their offerings. It is now my pleasure to introduce Professor Pruneri. Professor Pruneri is a full professor in pathology at the University of Milan School of Medicine and chair of the Department of Advanced Diagnostics, National Cancer Institute of Milan, a comprehensive cancer center fully equipped for translational research and innovative care, including a molecular lab for next-gen sequencing. He's devoted to translational research programs, currently focused on breast pathology, and sustained by several national and international peer-reviewed grants, resulting in more than 390 publications, yielding to an H-index of 60. He is involved in several international networks, including the International Breast Cancer Study Group, where he was appointed as chair of the Translational Research Working Group, and the International Immuno-Oncology Working Group, focused on the validation of biomarkers for immune therapies. He is editor-in-chief of Tumor Journal and formerly the specialty editor for the breast and in charge of the precision medicine program at INT Milan. Thank you for joining us today, Professor Pruneri. We're excited to hear from you. And with that, I'll turn it over to you.
Thank you so much, Ian, and thank you to Diaceutics to giving me the opportunity to talk about biomarkers for ADC. This is my declaration of interest. And the first issue is trying to assess how we could get the selection of biomarkers for ADC. In principle, what we should try to do is having the chance to select an antigen that has its highest expression in cancer cells and the lowest or no expression in normal cells. This is in order to balance the activity and the toxicity of antibody drug conjugates that, as we know, is getting momentum because they are benefiting different types of cancer patients as has been proven in many registered clinical trials. So what we have to do is, as pathologists, is trying to get the best biomarker in order to select the population that is going to benefit from this type of antibodies, trying to avoid the on-target off-tumor and off-target off-tumor side effects, which are associated with this type of therapy. So this is quite counterintuitive with respect to what we did in the past, because with regard to HER2, that is, the model for as an ADC biomarker, because we know that the first generation of ADC, that is TDNX, was generated according to the expression of HER2, high expression of HER2 on the membrane of tumor cells. And in fact, what we did in the past was trying to select the so-called 3+ tumors, so the tumors in which there was a circumferential membrane staining, complete, intense, in more than 10% of tumor cells. And we tried to differentiate the HER2 positive cells from the normal cells, in which the immunoreactivity wouldn't be so high and was very, very faint, in order to differentiate positive and negative population. This is the ASCO-CAP guidelines for HER2 assessment in breast cancer, as was generated in 2018. And we see that we have the positive tumors, immunohistochemistry 3+, as we mentioned. Then there are the so-called equivocal tumors, in which we have again a complete membrane staining, but it is not that high, is moderate. And in this case, the tumor should be classified as equivocal, and then we have to order an in situ hybridization test in order to validate the positivity of this kind of tumors. And then there were the so-called negative tumors, so the tumor that was not be selected for a therapy with trastuzumab or other type of drugs against HER2 positive tumors. And these were the tumor with incomplete membrane staining or no staining at all, so the so-called 1+ or 0+. But now, I mean, we should try to assess a different kind of immunoreactivity, because we know that ADC, they bind to surface antigens, and the higher the receptor density is, the better. And immunohistochemistry is the biomarker of choice. We know that, I mean, immunohistochemistry is the most distributed, affordable, I would say reproducible. We will discuss about that, a quantifiable approach in our labs. And but we have to, reverse the approach with regard to HER2 positivity in breast cancer, as we know it, because we have to set the lower level of expression to which ADC is still clinically active. And we see that this is an ongoing approach that we will discuss during this presentation. When we are talking about immunohistochemistry, we know that there are many factors that possibly affecting the immunohistochemical results. I will not get through all these type of possible issues. Let me just underline the fact that, of course, the type of fixation and duration of fixation is affecting that very much the results of immunohistochemistry. So what is very important is that since these antibody drug conjugates, the biomarkers are immunohistochemical, in most of the cases based, we have to refine and be very careful to our pre-analytical steps in order to have reproducible results. Let's just focus on HER2 immunoreactivity as a possible biomarker of ADC. I would just get through very quickly gastric, breast, lung, and diagnostic approach. First of all, we have to underline the fact that, as has been demonstrated in the DAISY trial, the ADC, trastuzumab deruxtecan, in this case, they are working in all the population of patients. You see here the HER2 positive tumors according to the 3+ classification, this HER2 low, but also the HER2 completely negative. Of course, the best results were observed in the population of HER2 positive tumors according to the 3+ tumors, but you see that there is a very important signal also in the HER2 low, but also in a very small population of patients, 37 patients with that were considered completely negative. So we have a drug that is working not only in the HER2 3+, but also in the HER2 low, so the so-called HER2 low population. That is a population that, according to the original guidelines, was this equivocal or 1+, but also in the negative population. And so we refine a new population of tumors that is the HER2 low, and we recently reported on behalf of ESMO a new guidelines for defining this kind of population. And you see that, of course, as an example, we have the HER2 positive, that is again an intense complete membrane staining in more than 10% of invasive tumor cells. These are the 3+, HER2 positive, and the HER2 positive according to the new classification. Then there are the HER2 amplified, and again they are HER2 positive. Then there are the HER2 non-amplified, and in this case, according to the original classification, these tumors were deemed to be HER2 negative, and now they are considered HER2 low. The same is for the 1+, they are HER2 low, and when we released the ESMO, these ESMO guidelines, the results of the Destiny Breast 06 were not yet published, and so we will discuss this issue in a second. These are the results of the Destiny 06, according to the presentation, the recent presentation by Beppe Viale at ESMO 2024. These cases were considered, according to ESMO classification, as HER2 negative, but then the others, according to the results of the registrative trials, they were able again to set the population, the so-called HER2 ultra low, and this population of patients were still benefiting from a treatment with trastuzumab deruxtecan. These are again the results of the studies. The others were able to compare the results evaluated centrally and locally. This is a quite busy slide. Let me just summarize the fact that there was an overall percent agreement of 77.8% for the HER2 low, but then when the others were able to evaluate the samples which were scored as immunohistochemical 0 locally, the central testing found that 35% were still immunohistochemistry 0, but then there were 64% of the patients which were considered as HER2 ultra low and low. So the others were able to identify more than half of the patient that was originally considered as completely negative as HER2 low, and so able to benefit from the treatment. So it is very important to underline this fact. It is important to know that there could be an absence of reproducibility with regard to HER2 low expression from inter-observer and also intra-observer. This is not that surprising in my opinion, because as we underlined, we were trained to separate very clearly the positive from the negative in the past, so the 3+ from all the others. Now we know very well that there is a new biomarker that is HER2 low, and so these days we have to reevaluate, and these are the suggestions of the authors of the paper presented at ESMO. You should reevaluate the slides, and in case of negativity, you should retest the slides in order to obtain more reliable results. And these are just data underlying the fact that in different settings there is some change in the evaluation of these parameters. Let me introduce the guidelines for HER2 immunohistochemistry in gastric cancer. They are quite different from that reported in breast cancer. You see that again, there is no reactivity or membranous reactivity in less than 10% of tumor cells. In this case, the tumor are considered negative. The same are for 1+, 2+ are still equivocal, and they have to be tested by in situ hybridization. 3+, they are positive. There are also, some suggestion from the guidelines with regard to the type of fixative and how to proceed with the fixation, the processing of the histology, and also the identification of the areas with invasive adenocarcinoma, because it is very important to take in mind that in this case, especially in gastric cancer, heterogeneity is an issue, so you have to consider this fact. Some data related to the HER2 in gastric cancer as a biomarker for ADC. You see in this paper that was the Destiny Gastric 01 trial, there is an objective response rate of 42% in the HER2 3+ population. And you see that there are also some effect in the HER2 immunohistochemical 2 in situ hybridization negative population, 26.3, much lower in the HER2 1+ population. So it seems that in gastric cancer, there is a nuance, a gradient of intensity that is associated with a different response of this kind of patients. But it's very important to underline that in this trial, the population was selected according to the expression of HER2, and the results were collected accordingly. Trastuzumab deruxtecan was also evaluated in a so-called agnostic approach, so in different types of tumor. The Destiny Pan tumor 02, the patients were recruited with advanced solid tumors not eligible for other kind of curative therapy. Second line HER2 expression immunohistochemical, again 3+ or 2+. Their local test or central test was allowed by HERCEP test. If local test, if not feasible, the blocks were centralized and analyzed accordingly. And these are the results you see in this focus on gynecological cancer. The results, they are very important. Again, this is objective response rate, very high. More than 50% in all the population. You see 84% in endometrial cancer in the 3+, 75% in the cervical, and 63% in the ovarian cancer. Again, it seems to be a gradient according to the density of the immunoreactivity on the membrane, also in the agnostic, in the Destiny trial, in the Pan-Destiny trial. A focus on ovarian cancer is quite important to underline the fact that you see the breakdown of immunoreactivity according to other types of clinical, pathological, and molecular data. You see that the 3+ they were much more common in tumor with the wild-type BRCA, proficient with regard to mismatch repair pathway, and with the PD-L1 low. These are the population of patients with ovarian cancer with the highest, the poorest prognosis in the clinical trial. So it is quite reassuring the fact that the 3+, the HER2 3+ that can be actioned by trastuzumab deruxtecan is in a population that has more aggressive features, and also in the histotypes which are not that common in ovarian cancer. The same is for endometrial and cervical cancer. You see the most uncommon tumors, serous, clear cell, and mixed. You see the percentage of 2+ and 3+. You see that is much higher in this kind of population than the endometrioid population. This is very important because we know that this population usually is the population without biomarkers for personalized therapy, and so these kind of patients could be treated by trastuzumab deruxtecan. These are the data with regard to lung. Again, in this case, HER2 3+ identifies a trastuzumab deruxtecan responder setting. Again, you see the cohort 1 of the study. You see that in this case, the objective response rate was 26.5%. And in cohort 1 and cohort 1A, it was 34.1%, and it was much higher in patients with immunohistochemical 3+. Again, underline the fact that probably in this case, addressing a highest prevalence density of the immunohistochemistry is very important to detect HER2 as a biomarker. Accordingly to this data, HER2 positive immunohistochemical 3+ solid tumors in this kind of setting on April 5, 2024, trastuzumab deruxtecan received an accelerated for patients with unresectable or metastatic HER2 positive immunohistochemical 3+ solid tumors. who have received prior systemic treatment have no satisfactory alternative treatment options. So it is very important, assess this kind of biomarker in this population according to the guidelines we just mentioned. Let me just focus on folate receptor alpha, because we are just talking about the story of HER2, and this is a very reassuring story. So we have the ability of detect very precisely the immunohistochemical results on this kind of tumors. Let me, talk very quickly, tell you very quickly a different story, but with a very good final. This was the results of the 401 trial. This trial were based on folate receptor alpha immunohistochemistry with and that there was a ADC specifically raised against this kind of antigen, and you see that the results were negative. And this was a phase 3 prospective trial, so the results were very disappointing. These are the percentage of expression of folate receptor alpha in different kind of population, but it's very important to underline the fact that this prospective trial was negative. But then we understood why it was negative. In the phase 1 trials on the same drug, on folate receptor alpha antigen, the author used a very precise scoring system that was a PS2 plus scoring. So the eligibility that was determined by staining intensity and percentage of tumor cells staining at 0, 1 plus, 2 plus, or 3 plus, and this score was considering positive only the population with equal to or more than 50% tumor cell with folate receptor alpha membrane staining with at least 2 plus intensity. On the contrary, in the forward trial, the author used a different scoring system, and you see that the results were different according to the breakdown of the type of immunoreactivity considered the two scoring system. And so we knew that the trial did not meet its primary endpoint, but the benefit was observed in the high folate receptor alpha subgroup. So the author were able to find out that there was a benefit in a post-hoc analysis, and there were consistent signals of activity across all efficacy endpoints in high folate receptor alpha subgroups, progression-free survival, objective response rate, and overall survival. And so they were able to design a new prospective trial that was the MIRASOL trial, and the results of the MIRASOL trial, they were positive. So this is, learning us that it is very important to design trials according to the biomarker, and the design must be very precise, reproducible. So biomarker, they are, very important even in the era of ADCs. TROP2, with regard to lung, endometrial, and ovarian cancer, TROP2, we know that it's widely distributed as an antigen. It is a key regulator of different pathways, and is expressed in different tumor types. And you see here the difference between normal and tumors. As we mentioned, it is very important to try to obtain a gradient of expression between tumor and normal cells. And we see that there are a couple of settings in which this kind of delta is quite important and evident. We know the data of the TROPION-Lung01. In this case, the patient were not recruited according to the expression of TROP2. And so it seems that in this case we do not need a biomarker. But let me just mention this trial, this study. In this study, the authors were able to reevaluate the very same blocks of the patient included in the TROPION-Lung01 in a retrospective way, and they applied a quite complex digital computational analysis that measured the delta, the ratio between membrane and membrane plus cytoplasmic immunoreactivity. And according to this computational approach, the authors were able that this biomarker was able to detect a population with a very fine and nice prognosis. So of course they are post-hoc data, retrospective data, even if they were collected in a prospective trial. The analysis is quite time consuming. and we have to see its possible reproducibility. But let me tell you that, of course, the other, they are to be commended because they were able to, to propose a new way of considering a biomarker in prospective clinical trial for TROP2 positive tumors. And in fact, now we are awaiting the results of the Icarus Lung 01 trial. In this study, you see that this study is a quite complex study, but let me just underline the fact that there is a very important translational backbone, and there is also the chance to select the patient according to the TROP2 expression by immunohistochemistry. MET, just as an example, this is just an example of the complexity that we are encountering as a pathology lab in our daily life. You see how many variants of MET we have to consider in our daily life. There are MET mutations, MET gene amplifications, MET fusions, and nowadays there are also immunoreactivity for MET, because there are new ADC which are coming into the clinical practice, and that they are tested in clinical trials. So there is immunohistochemistry, genomic analysis for MET. And let me just mention these results for in telizotuzumab vedotin, an ADC targeting c-MET. And in this study, the authors, they were able to evaluate the H-score for MET. So they were able to evaluate the relative immunoreactivity of the completely negative tumors, the tumor with a very low expression, moderate expression, high expression. Of course, the number of the prevalence of cell were multiplied by the intensity, and at the end of the day, you have the so-called H-score, and you see that the overexpression of c-MET was defined by an H-score of more than 150 of membrane staining, and the cutoff was chosen by the sponsor, so to select patients which are more likely to benefit from Teliso-V. And and it's very important to see that the activity again was associated with MET overexpression. So this is telling us that probably, as we discussed with HER2, especially, there is quite a relationship between the density of expression of a specific antigen on the membrane and the activity of the drug. Of course, this may be evaluated, provided that the pre-analytical steps and the interpretive results are collected appropriately. And you see, in fact, the luminosity trial in this case, we saw that there was a quite higher expression for a patient with a c-MET high according to the H-score. And I think that these data, they are quite interesting and encouraging for new clinical trials evaluating anti-MET ADC in the clinical research. I would just mention, including 18.2, of course, this is gaining momentum in gastric and in gastric cancer especially. And these are the data I'm willing to show you of this clinical trial, just in order to underline the fact that it is very important that the author pre-specified very carefully the type of antibody, the type of platform on which the antibody should be run, and the type of interpretation with a specific cutoff. I think that this is the right way of proceeding for clinical trials with ADC and a specific biomarker. And in fact, you see the results that were very encouraging and benefiting patients with a high expression of Claudin 18.2. Finally, let me talk about HER2 mutation, because for ADC there are not just the immunohistochemistry, so immunostaining, it is mutation as well. And these are the data coming from the Lung 01 and the Lung 02. In this trial was a positive trial for patients with HER2 mutation. It is important to underline that in this trial, the authors use the OncoMIND-Dx target test, the Thermo Fisher Scientific. You see here the genes which are included within the panel. and the way of calling a copy number gain, and of course HER2 immunoreactivity, because in this trial you see that the patients were included according to HER2 mutation and HER2 immunostaining, and in fact the results of the patient included according to scoring, the HER2 3+ scoring and 2+ scoring. We just mentioned it in the previous slides. These are the data related to the HER2 variants. You see that there are especially HER2 exon 20 insertions, and you see that is quite a different feature respect with other type of tumors. In lung cancer, this is the most frequent alteration with regard to HER2 mutations. You see that there are a number of different mutations in this population, and that there is a 4.2% of non-small cell lung cancer in this trial had HER2 alteration, including exon 20 insertions. Which were 1.5%. So they are representing most of the mutations, and these are the results of the clinical trial. You see that the objective response rate was very high, 55%, and it was completely independent of the type of HER2 mutation, exon and subtype, HER2 protein expression, gene amplification, and prior HER2 TKI therapy. Why the HER2 mutation is going to confer a benefit to patients treated with ADC? Probably because, as has been demonstrated, HER2 mutation is going to accelerate the internalization, so the trafficking of the membrane antigen, and this is, of course, benefiting the activity of the drug as soon as the drug is getting bound to the antigen. And as you see here, the trafficking index that is much higher in patients with HER2 mutation than in patients with wild type. And you see here that is highlighted by this colorimeter assay. So it is important, let me just conclude my presentation, considering how it is important to have, a lab that is able to run different tests. We have been talking about immunohistochemistry, and now we are talking about next generation sequencing. Let me just mention what we are doing within our institution. Of course, there are many institutions doing that every day across Europe and the world. What we are doing at the moment is profiling all patients with a somatic target comprehensive genomic profiling panel. In the past, we limited the analysis to smaller panel up to 50 genes, but now we escalate to a comprehensive genomic profiling approach that is, of course, related to the molecular tumor board discussion, and a couple of possible translational studies which are linked, of course, to this kind of analysis. These are the data on 25 pathogenic HER2 variants over more than 1,200 tumors profiled by comprehensive genomic profiling. This is the distribution of exon 20 variants, and which are more or less the same distribution we saw in the Destiny lung. And it is very important also to be able in our pathology lab to validate the comprehensive genomic profiling approach to detect copy number variation. You know that you have to do that because according to the comprehensive genomic profiling panels, you are able to detect especially copy number gain much more than loss, of course, and you have to validate these results in order to be as robust as possible. These are just data collected in our experience, and you see that with the NGS we are able to get a positive predictive value of more than 70% and negative predictive value of more than 90%. So this is meaning that NGS is a possible screening method for copy number variation that is in turn important for select patients with possible HER2 overexpression. So this was my last slide. Let me just collect my take-home message. So besides HER2, biomarkers are still uncommonly used for patient stratification, but we saw that there are new interesting data for TROP2, for MET, and for other biomarkers. Most ADC biomarkers, they are identified by immunohistochemistry, so please be careful with the pre-analytical phases, which are very crucial, especially you have to include quality controls in your analysis, discuss the results within the multidisciplinary teams and the molecular tumor board. We have different antibodies, procedure and scoring systems, so education and proper staffing and know-how, they are very important in order to build a robust pathology lab for biomarkers analysis. The biology of the ADC, cancer cell, and tumor microenvironment is not fully understood, so we need translational backbone studies in clinical trials, maybe and perhaps and preferentially including spatial transcriptomic in order to detect cell distribution. And we have to get back to immunohistochemistry, so we should probably collect omic data and then to get a reductionist approach to immunohistochemistry in order to distribute the analysis to the clinical labs. Possibly artificial intelligence-based automized analysis system could be implemented, and of course this is the other pillar for evolutionary pathology labs and training in our daily life. So this was my last slide, and now we can start the Q&A session.
Awesome. Thank you, Professor Pruneri, for that fantastic talk. Really appreciate it. So yeah, let's dive into some questions. The first one, how can the reproducibility of immunohistochemistry be increased?
This is a very important question. I mean, it's a difficult task because we know that especially, we have two problems here. One is the pre-analytical step of the analysis. And so you have to be as robust and reproducible as possible in order, with regard to the time of fixation, the type of fixation, the procedures. So you have to take care of that. We know that, for example, ASCO-CAP guidelines, they are, suggesting to get a fixation not more than from 24 to 72 hours, not less than, not more than that. So be careful about that. Then the second is, of course, the use of the antibodies, the platforms, and so on. But in my experience, what is very important is the interpretation. So we should be very consistent among pathology with regard to the interpretation. You saw the data produced by Beppe Viale and his group. You saw the absence of reproducibility related to the HER2 low among pathologists. So we have to do that. So be careful, developing procedures for your pre-analytical and analytical phases, and then be educated, trained for the identification and the interpretation of the results.
Fantastic. The next question, what are the barriers to using immunohistochemistry in pathology labs?
I mean, I think that there are barriers nowadays. I didn't expect to say that 10 years ago, but nowadays, all over the world, probably we are facing a shortage in personnel. So we are facing every year less and less doctors willing to do the pathologist. So of course the understaffing is a problem because of course we should have super specialized pathologists. Let me just mention the fact that according to EUSOMA, we should have at least 2 pathologists specialized in breast pathologists for each pathology lab. And this could not be possible according to the shortage in staffing of pathology. So how we can cope with that? Probably with the implementation of digital pathology. We should try to be as automated as possible. We should use artificial intelligence-based system for the analysis. And this could be also, I mean, this could be probably implementing and increasing and improving our reproducibility. Otherwise, I mean, I think that we could have, some flaws in doing that, because as you see, there are many biomarkers, different, way of scoring the tumors, and so on and so forth. So it is very difficult to have pathologists able to do everything. Let me just, get an example, similitude with oncologists. Nowadays there are no oncologists, treating every kind of cancer patient. There are super specialized oncologists, and more or less it should be the same for pathology. So I think that we have to, to increase, again, our pathology staff, talking with young pathologists, and this could be, I mean, an occasion. Try to, to convey to them how it's beautiful to do this kind of job, but also, of course, try to get advantage of the new technologies, which are very useful to us.
No, totally makes sense. Our next question is, how can a biomarker be evaluated in a clinical study?
I mean, we have been discussing. We have been mentioning different clinical trials, and I mean, we mentioned, positive and negative example, and I think that it is very important that pharma companies and the PIs of the studies, they should be very careful and to select the biomarker. And when they are going to select a biomarker, of course, they have to collect data. I mean, I would say collect robust data from phase 1 studies. They should know very well the distribution and within every specific type of tumors. They should select, as we saw for Claudin 18 in gastric cancer, a specific antibody that should be reproducible. They have to validate it. So there is a lot of work that, I would say, of pre-analytical work that should be done. Otherwise, as we saw with the forward trial in ovarian cancer, the result could be disappointing. We saw that many times. I remember, probably many of us are remembering the results of the TKIs against EGFR in the the first clinical trial. The trial was negative, and this was because the other were not able to to select the right population. But now we know that anti-EGFR is the backbone therapy for many patients with lung cancer. So selecting the right biomarkers is very important. Getting along with pathologists in order to decide how and when to test the biomarker could be very important, in my opinion.
And so, going along with that, do you believe that pathologists should be involved in clinical studies?
Yeah, sure. Yes, absolutely. They should be involved from the very beginning in clinical studies, because they have the the experience. They can be also because pathologists nowadays, they are not just running immunohistochemistry. As I show you, we are not running different type of testing. So we have the right vision in order to select the best biomarker. We know in many pathology labs how to validate a biomarker, select this the best biomarker among many, and to get an advice of the best biomarker to be used in a specific trial. I know, as we mentioned, for example, for TROP2, the TROP2 is very different difficult biomarker. So there have been many attempts to identify TROP2 as a biomarker. There is some signal, because TROP2, when TROP2 is higher, the results in the post-hoc analysis, they are positive, but we have been not able to select the proper method. But again, I think that we have to to keep trying to select the best biomarker, because otherwise we will be treating 100 patients in order to have the results in 50 patients. And for the other patients, as we show, there are possible many side effects which can be very difficult to cope with. So we have to select mean, this is our job. Select select at best the population to be treated with a specific drug.
Thank you for that. So our next question is, which assay should be used for evaluating HER2 mutations in clinical practice?
So it should be, I think that it should be, in my opinion, it should be HER2 mutation. Next generation sequencing in order to detect HER2 mutation. This is for ADCs, but this is something that we have to, we have to strategize. In my opinion, and what we are doing, for example, in Italy, when I'm working, we have set networks of lab with different levels of technology. There are many of the labs, they have at least immunohistochemistry, of course, classification of tumors, and then immunohistochemistry, in situ hybridization, and maybe RT-PCR. And they are doing a very good job for most of the patients. Then there are, central labs in which you can run a next generation sequencing analysis with comprehensive genomic profiling analysis, for example. So let me tell you that for HER2 mutation, I would vote for next generation sequencing, because it is allowing you not only to detect HER2 mutation, but other variants in other genes. And we have been talking with regard to ADCs, we have been talking about lung tumors, and it is very important to have data when we are dealing with lung tumors, not only for HER2, but also for a couple of other genes, of course, including EGFR, KRAS, and so on and so forth. So this is the method of choice, in my opinion. And if you haven't a lab with an NGS platform, it is better to centralize in another lab, which have all the facilities in order to get the best service to your patients.
Awesome. And the next question is, do you believe it is important to have real-world evidence to better utilize clinical study data?
Oh, wow, absolutely. Absolutely. Thank you for this question. I'm, firmly convinced that real-world data, they are at least as important. I would underline, at least as important as data stemming from registrative trials, because of course we have to collect data in order to, I would say, to validate in our real life the results of registrative trials, in order to accumulate new data related to our specific population. And let me tell you, also for getting information to the national health system. For example, in Europe, we have, in most of the country, we have national health system, more or less universalistic, but it's very important to collecting real world data in our centers, just in order to also to get an advice to the stakeholders, for example, for which kind of drug should be prioritized according to side effects, I would say prevalence in our population, capability of detecting the analysis in our daily practice, and so on and so forth. So, but in order to do that, these are the good news. I would say that we still have some flaws in doing that, because I think that, of course, we have many positive examples in Europe, especially in France. I would say in Germany, in the Netherlands, of centralization. Let me tell you that in Italy we have, in my opinion, to get better in the future, because we are many big centers, but we have to build a real network in order to share the data, because this is very important for the Ministry of Health of our country, also for the Association of Patients, of course, the scientific association, and so on and so forth. So, in my opinion, producing good data and archiving good data and sharing good data is the key for the future.
Awesome. And thank you for that. That was the last question we had. So a huge thank you again to Professor Pruneri for this fantastic presentation. And thank you to everyone in the audience as well for taking the time. We encourage everyone to stay in touch with Diaceutics to learn when our next event is. And we hope everyone has a good rest of their day. Thank you.
Thank you, Ian. See you. Bye-bye. Ciao.